Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out isofit.com. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. This episode is powered by Dr. Ray Gorman, founder of Engage Movement. Learn how to boost your income without relying on sessions. Get a free training on the blended practice model by following at Ray Gorman DPT on Instagram. Osama, welcome to the podcast. I'm so glad we're finally able to do this, man. You are an incredible individual with so much knowledge, and I appreciate all that you've done to help me out and teach me in relation to dry needling over the past couple of years, man. For people who aren't familiar with you, or maybe they haven't seen the work that you're doing that way, would you mind filling them in a little bit about who you are and all the great stuff you're doing?
Thank you, Dan, man. I really appreciate you having me here. And yeah, it was a lot of back and forth as we are trying to get this set up, but we both have busy lives going on. So my name is Osama. I'm a physical therapist. I'm just north of Detroit, Michigan, where I'm born and raised. And I went through undergrad physical therapy school in the area. And after physical therapy school, I just felt like I didn't really know how to properly help somebody. We learned a lot about how to not hurt people and how to pass our board exam and all these different systems, but not enough about like actual orthopedic care. So I knew that I wanted to do more. So I immediately went into a fellowship through the American Academy of Manipulative Therapy. That's an orthopedic fellowship. Took about 18 months to complete that. Very, very clinical. Like we are learning in a classroom and then immediately can apply it to our patients. There's mentorship involved with that, and there's data collection for research. So really, it does try to make you a well-rounded clinician. We're going through like evaluation, all that. So I honestly really enjoyed my time in fellowship, and I do think that made me a significantly better clinician because I felt like I was actually helping people and utilizing these skills that could make an immediate change, both in the short term, but also in the long term. But one thing that I really fell in love with was dry needling. A lot of different ways to utilize needling, which I'm sure we're going to get into, but when I was going through fellowship, we could take the classes unlimited times. So I tried to attend the classes if they were ever in my area. I would drive to Chicago, I would drive to Cincinnati. We had a few up in Michigan. So I would drive around and try to take these classes from different instructors, and I would read a lot of research on it. And then obviously I'm using it on patients as well. So I was seeing a lot of the effects of it. And from my love for needling, and I was able to do a medical mission trip that same year during my fellowship, where I was able to go do even more of it and teach other clinicians in another country how to utilize it. All of that really rounded my education of dry needling, and I eventually got the opportunity, thankfully, to teach for the American Academy of Manipulative Therapy. So I travel to other states and teach other clinicians how to dry needle. I'm at you in Richmond, Virginia, and coincidentally, I'm in Richmond this weekend. So it's been nice. I've been doing this for about 2 years and a few months now. I've been teaching, and then I also take on mentees for the fellowship, and I have my own cash practice up in Michigan as well.
And you're a busy guy. You're truly someone who's kind of embodied that 10,000 hour rule that it takes to master something that way. And in particular, in relation to the dry needling, this is something that I feel has been a very hot topic. And the more time passes, the more interest I've seen in it from clinicians, from patients, from parents, and so on that way. So much so that I'd say at least 3, 4 times a week, someone is asking me, hey, what is dry needling? Should we be doing dry needling for me? Oh, is it just like acupuncture? I get so many different questions about it on the week to week that way. And I think now more than ever, especially with some of these AI advancements, patients are getting smarter and smarter. They're getting answers. They're getting told about dry needling. Other people are saying, hey, I did it and it worked really well for me. So naturally, people are more curious and bringing it up more often that way. But for people who aren't familiar with dry needling, maybe they haven't taken a course themselves, maybe they've never had needling done to themselves, what exactly is it and how does it differ from that traditional acupuncture school of thought, if you will?
Absolutely, you're right. I mean, clinicians are looking more into it. We're still filling up our classes every single time I teach. I got 25 people in the class. So we're still filling out these classes overall. And patients more and more so are looking for it. There is actually a study that showed that there are increased Google searches for dry needling now, where patients are the ones that are seeking this out. I think a big reason for that is they've tried other things that haven't worked. they're looking for other avenues that might get them some pain relief. And maybe some of their friends have tried it, so they start looking more and more into it. And that's by far the majority of people that find me online are looking for dry needling. And I mean, they see it on my website. I don't have it listed that many times. But they also see it in my reviews because it's making such a big difference in people's lives that they're including it in their Google reviews. So dry needling is just the use of a monofilament needle. It is a needle that's stainless steel. There is no medication, and we are putting that into problem areas in a patient's body in order to stimulate their own natural healing process. They are the same needles as acupuncture needles, but we are not putting needles in as to follow a traditional Chinese diagnosis or an Eastern medicine diagnosis. So, for example, like there is a needle that goes into the infraspinatus in the shoulder. That's one of the rotator cuff muscles. And that point is for the small intestine. So, something in acupuncture, they might utilize that in order to treat a small intestine problem, while I would utilize that for a rotator cuff issue. And there's this is acupuncture itself is not something that I'm very well trained in because I didn't learn traditional Chinese medicine. I did learn it from a Western perspective, and we do utilize acupuncture studies. Just because a study was done by a different profession, it doesn't mean that I disregard it. Just like how if there was a manipulation study or an adjustment study that was done by a chiropractor, I don't not read that study because it was done by a chiropractor because I can still do manipulations under my scope. So I'm going to utilize that research and I can apply it to my patients as well. Same thing with an exercise physiologist and utilizing exercises because that's a big thing that I do as well. And it's the same case with acupuncture. So if there is a study that looks at acupuncture for low back pain and they're putting needles in the low back, then I can utilize that study and treat my patients according to the same points. Nice thing about utilizing acupuncture, or excuse me, acupoints, is that depending on the research you look at, there's an overlap between trigger points and acupoints between 77 and 93%. It's a really big overlap that gives us essentially a nice map to start off with. It doesn't mean that we have to do all these points for every single condition, but it gives us an outline where we can pick and choose what we think that patient would benefit most from. There's also studies that are acupuncture studies that are just utilizing a regular diagnosis, carpal tunnel syndrome, lateral elbow pain, headaches. Those are acupuncture studies that are not treating liver blood stagnation, so I can still utilize those studies. There's been studies that have been published in JOSPT that have used acupuncture and dry needling interchangeably. So those are some of the reasons why we still might utilize acupuncture research or acupoints. But what I want to emphasize is that with dry needling, we are not doing traditional Eastern medicine. I'm trying to stimulate the body's own healing response. We'll get a little bit more into that, but essentially getting more blood flow to the area and getting a natural opioid release, so your body's own painkillers over to the area of pain.
Yeah, no, that's incredibly well said, Osama. And just to run it back, I mean, one of the main things I like about that AcuPoint system, as you mentioned, is we now have a common language between providers of the areas we're trying to target with a needle, if you will, right? So instead of saying, well, yeah, I just felt around, search and destroy, and just trigger point, blew up this whole area that way, it's like, hey, look, I can be a lot more specific.
Mhm.
So if for some reason, hypothetically, say I'm leaving and someone else is going to carry over the needling care of plan of care for someone, that way they can actually look at it, understand, hey, this is roughly where he was at. This is why he was doing it, and kind of continue in a similar fashion that way. I also think, just from an overall like clinical effectiveness standpoint, if you're constantly shooting all over the place instead of kind of like targeted in one specific area, you're not going to know what's actually moving the needle forward, pun intended, versus like just kind of leaving people stuck where they are that way. It's ultimately a way to kind of look at each patient you work with as their own case study. You can look at the regions that you targeted very specifically and say, hey, look, I worked here. This made this effect. Maybe I need to continue that. Or, hey, I targeted these muscular regions. We didn't see the progress we expected. What am I missing? Where do I go next? As opposed to, well, I just felt all around and blasted everything, right? We're trying to be a little bit more sniper-like than shotgun focused here, if you will, that way. And I think that's one of the common things I've heard from people that have had needling by other providers that haven't had good outcomes with it is they feel like they go in and needles are just blasted all over the place. And it's almost a little bit more stressful for them than it is actually like relieving and therapeutic, if you will. Not to say that, the effect of needling is always, relaxing and calming for people, but they feel like their provider just doesn't have a clear idea where they're going. And they also feel like almost like beat up, like in a bad way afterwards. And a lot of them tell me that, they were moving the needles all around and jerking them real quick and different things. And they just didn't necessarily like how that felt. And I use a slightly different approach, one more in line with what you taught, where it's like, hey, instead of moving the needles up and down or blasting them all over the place, it's like we try and be a little bit more methodical, but we also leave them in for a longer period of time. I like to wind the needles a lot. That was something that you taught that way. You mentioned the opioid response that way. I mean, physiologically, anything I can do to like naturally like dose the body with its own natural painkillers, like if people leave feeling better than they did walking in from that effect, like I'm going to make that transaction every time. And again, if I'm seeing that kind of effect through an approach, I'm not going to change my approach when I'm getting the outcomes I want with it that way.
I agree with you 100%. There's a reason that we teach it this way is because it's typically people's first exposure to it, clinicians being. So if they've never done this before, we want to give them somewhere to at least start off, and then you can start to deviate from that as you have more and more experience and actually see some results. Otherwise, you're just guessing. The problem with just looking for trigger points is a few. One, that means you can only target contractile tissue because only muscles have trigger points. You're not going to find a trigger point in a tendon. You're not going to find it in or on a bone or a ligament or a nerve. So you're essentially disregarding all these other things that we could be treating with the needle if you're only looking for the trigger point. Along with that, there's between a 3.3 and 6.6 centimeter error to find trigger points. So you and I, Dan, would probably not find the same exact point on a patient. And the needles that we're using at most are 0.3 or 0.35 millimeters in diameter. So even more unlikely that we're going to get it. And then what a lot of people are taught with trigger point dry needling is that they go into a trigger point, find a twitch, remove it, and go right back in. And they're essentially jackhammering a muscle fiber, which is shown to cause too much damage and typically is going to make the patient way too sore. I ask patients, because a lot of people have had dry needling done by the time they come see me. And I'll ask them, how do they needle you? Like, did they keep the needles in for 15 to 20 minutes? And if they say no, immediately I know that they're not trained in the same way that I am. Did they use electricity? Typically, patients say no. Did they come back and spin the needles every few minutes? Almost everybody says no to that. Those are really, really big deals that will show that I'm probably going to get them a better outcome than the other clinician did. And needles, just a disclaimer, it's not everything that we do. It's a part of what we do, because if I can get somebody a result just a little bit faster, if I can get them to sleep better that night, have them in less pain, it gives us a window of opportunity to really load them. So while everybody else is looking for these long-term results, I'm able to get a short-term result and a long-term result. And patients typically are going to trust me because I'm able to get them in effect relatively quickly. You were talking about how patients can leave feeling a little bit beat up or sore. There was a study that showed that 51% of patients that get needled don't want to be needled again. Half of the patients that we put needles in are not interested in having that done to them again, which shows a few things. One, they were way too sore. And two, they didn't get the result they were looking for. Because even if they were sore, if they felt better, they might say it's worth it. I'm down to try that again. I've had this pain for years. But if it's twofold. If they got sore and they didn't get the result, why would they ever want to experience that again? And I emphasize this to people in that you have to make sure it's already an uncomfortable technique. We want to make it as comfortable as possible for our patients. So that means that you need to be confident when you're holding and loading a needle, when you're inserting it into a patient. If you are doing it in a lazy way or you look a little bit awkward with a needle, patients immediately are not going to trust you. So you have to make sure that you're the clinician, you're the professional. They're seeking out your help because they don't know what to do about their pain. So that the aspect of coming in with confidence and inserting a needle confidently, and you'll see this on social media where people are doing this poorly the entire time, where they will like tap a needle multiple times and they'll wind it and they'll tent and try to rip it out of the body. I've seen this. And these people have thousands of followers. So naturally, everybody thinks that they are the experts. But I've also seen the people that are experts that have thousands of followers putting needles straight up in somebody's lung. So just be careful with who is needling you, especially if they're near the lung field, and make sure that they have proper training. So one of the guys that we actually had reached out to, he's a chiropractor in Chicago, has 15,000 followers, is literally putting a needle in somebody's lung. And we reached out, and it comes out he actually isn't trained in needling. He just had to be a chiropractor in the state, and that gives him enough anatomy knowledge that the state allows him to needle, which means he's just going to hurt somebody eventually. And that person, I would imagine that he put a needle in, didn't end up getting a pneumothorax or a collapsed lung, because the body's incredibly resilient and it will typically heal itself. But you only got to make the mistake one time to ruin somebody's life, and also hurt your profession, hurt your own license, because that's kind of negligence. So all that being said, the way that we needle is a huge deal to me, making sure that it is as comfortable as possible for the patient, because we already know it's going to be uncomfortable. It needs to be uncomfortable. If we don't get an achy response, we probably didn't do enough. So we don't want to make it even more uncomfortable by giving them like a really sharp poke with the insertion and then jackhammering a trigger point. There's a lot of better ways to be needling a patient.
Yeah, I think that's so well said. To your point, it's uncomfortable when you have a needle in your body or several needles in your body. And you mentioned that we want that achy response, which, throws people off sometimes because, when I'm doing other manual techniques, they're looking for like that relieving effect. And this one, it's like we almost have to inflame the tissue a little bit in order to get it to heal, right? It's like, in one theory, anyways, restarting that inflammation process, if you will. But to your point, if we overinflame the tissue, if we move the needle too much, if we jackhammer it too much, now we're doing more harm than good. And I think I could be wrong about this, but the first rule in any kind of medical practice is to do no harm. So that's
Yes.
where again, to your point on the training and just knowing what you're doing and why you're doing it, right? This is not just an entry level, every clinician ever is going to be able to do this kind of thing, right? Maybe we'll get there eventually, but in my opinion, we're not there yet. We want to make sure we have an adequate knowledge of anatomy, of using the needle, because again, you're piercing the skin and putting something into someone else's body. There are some
Basic thing
risks
that we do.
associated with that, and you have to have respect for that. You have to know what you're doing, why you're doing it. And I think the more you have all those things kind of checked off, right? You begin with the end in mind. You know what the end goal is, and then you're reverse engineering the plan to get there and understanding how dry needling fits into that. The more successful you're going to be with this intervention. Again, if you're just shooting blind and going all over the place, this is not going to be an effective tool for you as a clinician. You have to have a robust framework for taking dry needling and implementing it into the patient population that you're working with.
In the same way that you say that not every clinician is appropriate to be doing this, not every patient is appropriate to be receiving this. We have to make sure it's actually something that will get them a result that they need, along with the other manual therapy techniques that we utilize or the other modalities and different exercises. I mean, like if somebody has an issue and you give them an exercise that it's not the best thing for them. It might irritate them. Same thing with needling. Or, I mean, if you did an exercise too early in somebody's rehab, or you tried, mobilizing a joint that's hypermobile, like the tool has to match the problem that the patient is having. So it's the same case with needling. We don't needle every single thing. And when we are needling, you got to make sure you're doing it appropriately. So we don't piston, we usually fan or cone. You got to wind the needle, or else you're just missing out on a bunch of the mechanisms of needling. You could also tense or periosteal pec, depending on where you are or why you're doing it. And then electrical stimulation and the Easton parameters that we typically use are within a very comfortable range. I know some others might use a very high frequency and like develop a tetany. So like there's actually a muscle contraction for the patient, where it's not like a comfortable tapping muscle contraction. It's like actually like a spasm almost. Not typically comfortable for a patient from what I've experienced, and also from what I've done to patients. So when you do it a lot, you get to see what actually works, what doesn't work. And sure, you're going to look at the research, because that is the first part of evidence-based practice. But evidence-based practice has three equal pillars, and that is evidence, the research that you're reading, clinical experience, what you've actually seen work and what you're good at doing, and patient's expectations. So if patient comes in and they say that they want needles, we're probably going to needle you day one because you're expecting this. You're probably going to have a positive outcome from that. Versus if they had a bad experience with needles, I literally don't even bring it up to them until I build the trust with them. And then they'll usually bring it up to me after like 2 or 3 weeks because I'm not pushing it. I'm trying other things. I'm already getting them a result. They're feeling better. I might bring it up maybe, or I'll bring it up in regards to another patient that had a similar case, but I'm not necessarily like pushing this on them because again, I've seen it work and the research says it works, but if a patient doesn't want it, it's probably not going to get them an outcome. So we're usually kind of like going to bring it in slowly or wait for them to bring it up to us. But don't only look at the research and forget about the other two equal pillars of evidence-based practice because not everything's been tested yet.
No, I think that's such a great point as well is, part of the evidence-based practice is, as you mentioned, the research, but part of it is just your own experience and own practice that way. I think we often forget about that. And it's one of those things too that I feel like understanding where your own experience and where the patient expectation fits into that evidence-based practice makes conversations with other providers easier as well, because I've had a lot of conversations with orthopedic providers. I've had conversations with strength coaches, athletic trainers, even other PTs and chiropractors at times that they just don't see the value in needling and they don't understand it and they don't get it. But then we try it with some of their patients and they see drastic changes ridiculously fast. And I think now more than ever, there's this growing pressure on providers to provide results in a very quick fashion. And if you don't, then ultimately you're a failure because you can't provide outcomes, which I mean that's a whole separate conversation. But we have to respond to this pressure in a way that does provide the outcomes that people are after. And I think needling is probably the most powerful tool, probably up there with spinal manipulation, depending on the patient and their overall diagnosis and presentation, that we have in our toolbox that can make those kind of changes so quickly that way. And I think once you start to see the value of, hey, look, to your point from before, needling is not going to be the only thing that we do. We're also going to load them. We're also going to progress them in other ways. But we can open up this window that we can actually do those things and make serious change in a matter of 20 to 30 minutes. Like I'm making that transaction every time. I'm blocking out time in my schedule to make sure we've got enough time for the needling. Because then when I do get to those things that are, heavy loaded, eccentrics, isometrics, whatever it is that way, that I'm, really putting a lot of stock in, we can actually do those. We get more out of it. And I haven't done a whole lot of own personal assessments on pre and post needling, but one of the things I've been really interested to see is as we reduce the pain response, right, from dry needling, is there any improvement in some of these other things that we like to obsess objectively, right? Like, hey, does someone put out more force output, or does someone have better muscular activation on EMG because, hey, it doesn't hurt as much now? And I mean, we don't necessarily have all the answers to these questions, but I think it's one of those things that, at least for me in my own experience, I see notable changes functionally, in a short amount of time after needling. And I think that there's something more to it just from the overall session flow and the impact it can have for yourself and the work that other providers are doing with the patient. Quick break, because if you're a rehab professional sick of burnout, this could be your answer. Engage Movement's blended practice model is a proven system built by Dr. Ray Gorman, a PT who walked away from the 55-hour-a-week grind and built a blended practice model that doubled his income while working less than 25 hours a week, and he didn't have to rely on the traditional way of selling sessions to do so. It's all about blending remote and in-person services, stacking monthly recurring revenue, and building a business that finally supports your life, not the other way around. This model isn't just theory. Real providers, including myself, are creating lives of freedom and flexibility without being tied to their schedule. And as a listener, you get free access to the complete training. DM my name, Dan, to @RayGormanDPT on Instagram and receive your free breakdown on the model.
Yeah, there's few studies, but there are some studies that show that it can work for like athletic recovery. So soreness essentially can help in improving that. And then there's a study that showed that it can work in soccer players to improve, I believe it was endurance of their quads. So there are some things that show within the research, but it's still very, very limited. I have seen it anecdotally in patients where they get, you can facilitate a muscle. So they'll get better muscle activation. They'll actually feel it turning on. They'll feel it burn. They'll feel it get sore afterward. I've felt that myself where I've been needled and then I played basketball the same day. And my performance is, I mean, I don't have I'm not a great basketball player, but I got a great jump shot. And it was even better on that day where there's better athletic performance that all from me being needled on that same day. I've had patients break PRs in half marathons, in 5Ks. Power lifters have no failed attempts and new PRs in deadlifts and squats. Recreational lifters break PRs in deadlifts. Now, there's a lot of other things that they are doing, right? It's not like the power lifter just got that because I needled her the day before she went out for a competition. I needled her because her back got tweaked the day before. But she felt so good afterward that she was not nervous pushing herself to do that. She put in all the training and then she's able to push herself a little bit more. So you were saying that we want to make sure we can like reduce their pain so that way we can do the things that really, really matter in the long term, which is loading them. If I can get somebody's pain down sooner, I can load them sooner, hopefully get them stronger sooner, and I can save them time and save them money and get them a better outcome because they're in less pain throughout. So all of that is really a positive reason to be utilizing needles. And again, you got to be utilizing in the right way. So just to talk a little bit about some of the mechanisms of needling, we know that if you have a trigger point, there are a lot of different theories for what causes a trigger point itself. And some people deny their existence. I do believe that trigger points exist. I just don't think there are only target for a needle. But essentially, if you have a sustained amount of acetylcholine at a neuromuscular junction, which will happen, you'll have a sustained amount of acetylcholine there from an acidic environment. So if you're having a sustained amount of acetylcholine at the neuromuscular junction, you're essentially going to have a low tone muscle contraction. And if we put a needle in that, it's like throwing a grenade into that neuromuscular junction and using up that remaining acetylcholine, which is one reason why we probably get a twitch. The twitch is also just a spinal reflex. It's not something that they are voluntarily doing. And the twitch is not everything because there is a poor correlation between pain and disability in the short term. If you were to have a twitch response, there is poor correlation in pain disability in the short term, and there's no studies in the long term. So the twitch cannot be everything that we are looking for, although it is still a target to be needling trigger points. That is from putting a needle in that one spot. But then if you do, let's say, fanning or coning, where you're just changing angles, so the needle goes into one spot, you could retract it and then redirect it and hit some different hot spots, whether you're going in a 3-dimensional or 2-dimensional pattern. That'll get you a lot closer to that room for error, that 3.3 to 6.6 centimeter error for finding trigger points. But also, it's going to create a lot less damage in the one area that you just went into 15 times when you pistoned that patient. Along with that, if I put a needle here, I can only affect it here. For those of you that are just listening, I'm just tapping my shirt. But if I grab that shirt and I spin it, just like we spin those needles, we can pull everything in towards the needle. So we're able to get a little bit of a wider effect with that needle when we are winding it. And we're able to get closer again to that room for error, but also if we're at some like sensitive areas, maybe you don't want to be right on top of a nerve, but you want to be close to it. Well, you can start to affect some of the tissue around that nerve and you're pulling in the fascia and all of that just by spinning that needle. Then you can also tent it, which is just spinning and pulling on it. That's a bit more aggressive, so it has to be the appropriate patient. And then also there's periosteal pecking, which is just tapping on the bone. So if you were to insert a needle like where the common extensor tendon attaches on the lateral elbow, you could just put a needle there and then tap on it to get more blood flow to the area because tendons have poor blood flow. That's a way to improve blood flow to the area. Same thing is done at joints where we could do that, like let's say at the knee joint. You're getting down at the joint line and then tapping right along the joint line to help get more blood flow to that area. But also it can promote chondrocytes, which is the precursor to cartilage. We know that you have to wind it to get the adenosine release. Adenosine is a vasodilator. It's going to help with pain. It can help downregulate this area in your brain that is it's responsible for the emotional response to pain. So those that have maybe a trauma associated with their pain, like they got, God forbid, like a car accident, or I had a patient once that was thrown off of a horse and she was so scared to go back and just pet a horse. Part of it is that she's just amped up because they had a trauma associated with it, and we could reduce that. And that only happens from the adenosine. And the adenosine only happens if you spin the needle. And then along with that, adenosine is what your body naturally will break down throughout the entire day to help you go to sleep at night. So if you guys are into sleep, just look up the Sleep Diplomat or Matthew Walker. He has a great book called Why We Sleep. And in that book, he talks about adenosine, how adenosine is built up in your brain over about 16 hours, which is why our wake windows are about 16 hours. And then it leads to something called sleep pressure, which is not literal. It's a figurative pressure where you can't stay awake any longer. You just start dozing off. That happens from adenosine. And adenosine will help you both with the timing of sleep and with actually falling asleep. While melatonin does not do that, melatonin just helps you know when to sleep, but it doesn't actually make you fall asleep. Point being that if we can promote adenosine, I'm doing it for pain, right? I'm doing it for more blood flow to the area. But if I can help with somebody's sleep, good. I want to help you with your sleep. Anecdotally, the closer I am to the head and neck region, the better they sleep. If I'm like needling their foot, it doesn't matter how much I spin the needle, they're probably not going to sleep that much better unless their foot pain was preventing them from sleeping. So those are some of the main mechanisms with needling. And then really the biggest of them is the endogenous opioid release. So if we can get more natural painkillers into that area, we can significantly reduce their pain and again give us a window of opportunity. We also will promote serotonin and norepinephrine. If we could promote serotonin, possibly in the future, this will be utilized for patients that take SSRIs, so like anxiety, PTSD, depression. They're already utilizing acupuncture. They're already utilizing, traditional Chinese medicine for those things. I am not as a physical therapist doing dry needling, but possibly in the future it will be something that we can consider that might be in our scope of practice because patients are only getting smarter. That's why they're looking these things up. They're looking for a provider that can do a lot of different things and not having to see, a physio, a chiro, an acupuncturist, massage therapist, a personal trainer. We kind of can do all of these things to an extent, maybe for different reasons. But if somebody's coming in for pain, I think I'm a good solution to be helping them with their pain and getting them back to high level performance.
I completely agree with that. And it's one of those things that I think a lot of younger athletes realize that a lot of the things they're after are not going to be, accomplished without a little bit of pain along the way. And again, going back to the pressure element, parents want answers and resolutions now more than ever. Coaches want resolutions now more than ever. And the amount of athletes I've had come in with back pain or, soft tissue pain, especially like places like the calf, for example. Like I love to needle the calf because some of those trigger points, as you mentioned, can be major sources of issue and can act up and, they'll try to dig in with different things and different tools and it just won't let go. But that's an area that I've noticed great impacts from needling. You mentioned the foot as well. Like I can't tell you how many times I'll have plantar fascia roll into the clinic. And I know you mentioned that medial calcaneal tubercle or tuberosity a
Yeah.
while back, and that being a gnarly point. And I mean, it's true, man. They feel it in the moment, but let me tell you what, it works so well. And even like shoulder patients that way as well, where they'll get, told they've got instability or like possible labrum that way. And a lot of their pain actually clears up when we do needling to different trigger point areas. Like you mentioned, the infraspinatus very early on, like cleaning up that infraspinatus and some of these other places that can actually refer pain to other portions of the shoulder makes a notable improvement for them. Now we can, as we mentioned, load, stabilize, and have an impact there as well. But in reality, like there's been very few things that I've seen walk into my clinic that don't benefit from dry needling. In fact, I can't think of one off the top of my head. And one of the things that I've found, at least for me, that's really opened my eyes is a lot of times if you're working with athletes, I don't care if you're sports PT, SCS, or strength coach or whatever that way, we think about things only in terms of sport, when in reality, we forget they're people that have lives outside of sport.
Yeah.
And like I distinctly remember there was one college lacrosse girl that came in because she was having headaches and she couldn't get them to go away. And it was actually impacting what she was trying to do from sport that way, but it impacts other things too, right? Quality of life, you mentioned sleep, even just school and academics that way, because kids are under a lot of stress. They've got to study, they've got to spend a lot of time in weird positions sometimes. So it's one of those things that I went right for the dry needling on that one, because it's like, hey, look, this is something I've seen help other people. They were, again, to your point from before, they wanted it, they expected it, and we had great outcomes that way. And I think, as you mentioned, there's a lot of different mechanisms at play. There's a lot of different ways we can do the needling. And I try to take the time to actually explain some of those to the patients that I'm working with, because, like you mentioned, they might not always have a great experience, even if I'm doing things in a very methodical, well thought out way. It still might not be 100% outcome on day one or day two that way. So it's having the conversation with them to know that there's other processes or other ways I can do it, right? Hey, day one, I was just spinning the needles. Hey, maybe we need something more aggressive and I'm going to spin and tent. Or hey, maybe, my frequency on the stim was a little too low. Let's try changing it next time and see if we feel something a little bit different. There's all these variables and factors that go into it. And again, since patients are only getting smarter, I think it pays dividends to tell them on the initial consult as much as you feel comfortable about that, because the more they know, the more comfortable they're going to feel throughout the entire process, and the more they're going to trust you as a provider, right? If you're just trying to like, yeah, it's going to help you, let's just get to it, and you rush into it, I feel like you're ultimately doing them a disservice by not adequately preparing them for what you're literally about to be putting into their body that way.
Well, I agree with you, especially with the dosage. Like, we're probably not going to get it right day one. Just like if you were to take a medication for something, it's not like the dose is always the right thing for that patient. And you likely are going to have to go back to your physician and adjust the dose to make sure that they can get you the best result with the fewest amount of side effects. Same idea with needling. I'm probably not going to get the right amount day one. I typically will do less on purpose because I either want to make them better or do nothing, but I don't want to make them too sore because, again, 51% of patients don't want to be needled again. So I need to make sure it's an appropriate amount, that they actually are tolerating it well, and that they'll let me do it again. I'll usually ask for 3 sessions of needles, and that will allow me time to either increase or decrease the dose depending on that patient in order to get them the result they're looking for. And while they're on the needles, we are going to be educating them, whether it's about the needles, like what we're actually doing with the needle, or we're talking about their lifestyle. And I think that there's a lot you can learn from a patient when you're just sitting down and having a conversation. Sometimes I'm just building rapport. So I'm just talking about life and learning more and more about them. But one time I had this patient that had low back pain, and she's on needles in her low back, and we're talking about sleep. And I'm trying to understand her pain because she wasn't improving as much as I was expecting her to. So I had a feeling we were missing something. So one thing I'll often ask my patients is, walk me through 24 hours. Like, just tell me what you do throughout a normal day. And she started off saying, I wake up in the morning and I get out of bed, and I start, I do this, this, and this. I'm like, how do you get out of bed? She's like, what do you mean? I'm like, how do you actually get out of your bed? She said, well, it depends. If Donut is sleeping here, I'm like, who's Donut? It's her cat sleeping right next to her. So she goes, if Donut's sleeping here, then I just kind of crawl out of bed. So she doesn't want to wake up her cat. So she's literally like going down towards the foot of the bed and like melting out of bed and then getting up to not wake up her cat. I was like, wake up your damn cat. And all of a sudden her pain started to get better. Where if I didn't have her on needles, if I didn't have the time to just talk to her, I probably wouldn't have learned that. I can guarantee you no other healthcare provider learned that. But when we addressed that aspect, her symptoms actually got significantly better. So it probably wasn't even the needles. It probably was just a activity modification because she was irritating her back first thing in the morning before she went and sat in a chair all day for her job. So the time that they are on needles is a very valuable time to be educating and learning from your patients. And that way, I do think that we can get them the overall result that they're looking for, because they are not coming in to you like that girl, Dan, that came in to see you for headaches while playing lacrosse. She didn't come in to see you to needle her. She came in to see you to get her headaches better. She doesn't care what you do to get her headaches better. She just was thinking maybe needles are the thing, and this guy does needling. So sure, we're gonna throw some needles in that patient and ideally get an outcome from that. But there's so many other things that we're able to do as rehab professionals, whether you're a a physio, a chiro, an athletic trainer. Like all of us have such a wide range of things that we are able to do within our profession that sure, needling is going to be part of it. But always remember, as somebody who needles a lot, it is not everything for your patient. And if you treat it as such, you're probably going to start to have limited outcomes. I mean, sure, you're going to help a lot of people. Just like if somebody gets off the couch and walks into a physical therapy clinic and you get them to do anything, their pain might get better. That's that sedentary patient that doesn't really matter what you do, doesn't need to be specific exercise, just have them do anything and they feel better because you're having them move in some way. Similarly with needles, if you throw needles in everybody, you're probably going to get some people better, but I guarantee you there will eventually be a person who you are going to get no outcome. And then what do? There's got to be something else in your toolbox. And that's really why I went to my fellowship, and I'm still learning. Like I'm doing ultrasonography now, so I needle a lot under ultrasound. I do a lot of manipulation. I do a lot of exercise, BFR. I do a lot of joint mobilizations. I do some soft tissue. So there's so many different things we can do within our profession. And I mean, even like let's say joint mob, there's different intensities. There's different types of joint mobs for that specific joint. Same thing with exercise. How heavy are we loading them? When are we loading them? What type of loading are we doing with them? Needles are no different. The needle is just the tool. You can utilize that tool how you see fit. So if you're going in and doing pistoning and jackhammering the muscle fiber and getting out, you're still technically doing dry needling. But what you do and what I do are definitely not the same thing. We're just utilizing the same tool. If that makes sense.
It does make a lot of sense. And I love the way that you worded that and kind of walk through that process. And to echo your point that way, man, I mean, I've learned a lot and definitely gained a lot of insight as to why someone might be coming to see me through the conversations I have with them. And it's interesting because I've actually had some people push back on that, other providers saying, well, you don't need to have those conversations. Or, other PT clinics, they see 3, 4, sometimes 5 patients in an hour. They're still, getting better, whatever that means. We never actually come to a common definition of what success looks like, but regardless, I catch and pick up on a lot of different things just by the conversations that I have with someone. And a lot of times I learn that sometimes I'm not the best person for them. They might need to see someone else. They might need a nutrition or dietitian consult. They might need a mental health consult. They might need other things that I just personally can't provide. As you mentioned, we can do a lot in our profession, and sometimes one of the most powerful things we can do is take the time that we have with someone, get to know them, get to know their story, and then just help point them in the right direction. A lot of times we can help, again, a lot of the time we can make a huge impact for people and get them where they want to be. But there's some times where we're just not the person for them. And it's okay to know that. It's okay to tap out. I think one of the biggest mistakes that I was kind of under the impression of getting out of school was that, well, you're a PT, you can do everything, you're autonomous, you can run the world on your own. And I lean a lot more into other providers now than I thought I was going to coming out of school that way. And that's especially true with the dry needling because, as you mentioned, it's not always the thing for everyone. Not every patient is right for it. So there's certain things that I want to rule out before I start sticking needles in there, right? For example, I had someone come in the other week, another lacrosse athlete. If you can't tell, I live in Maryland by the amount of lacrosse kids we get. And I'm very concerned of a possible stress fracture or something bony within the lumbar spine. I don't want to be the person to stick a ton of needles directly into that. I want to kind of rule that out before we stick a ton of needles in that area. So it's knowing again, what role do you play? What effect can you have? But as you mentioned before, when is the right time and not the right time for people? And I think the more you just emphasize treating people as people, the value that you can provide for them, even if it's just leaning into your own network or the impact you can have from a conversation and lifestyle modification with them, the better off you're going to be long term.
Yeah, I think the network is one of the biggest things. You're right. Like we have to know when to refer appropriately. And I think that's where patients start to fall into they have bad outlook on healthcare, is where somebody thinks they can fix everything and they either mess them up and make them worse, or they just didn't get them a result and they're like, why did I pay all this money? I think that our network is one of the most important things. So, I might have to send you to like an orthopedic surgeon. It might even be another physio. Like I send patients to other PTs in the area. I've had pelvic floor patients come in to see me. I'm like, I am not a pelvic floor therapist. This is not what I do. Or I've had people that have called me, and I always get on a phone call with any patient. If I'm going to take them on, I have to really be sure that I can hopefully get them the outlook that they're looking for. And with this one patient, I thought it was a neurological case. I'm like, you got to go see a neuro PT. Like this is not my thing, but I'm very thankful that I've built that network of different healthcare providers where I can send those patients to, and then hopefully as a collective we can get them that outcome. And I think it pays itself forward. I mean, actually, one guy that I sent to another, I sent him back to his primary care. He had some red flags. I sent him back to his physician, and then I didn't charge him for the eval because they didn't do anything. I'm not a good business owner. I'm just trying to be a good person. So I sent him to his primary care. He kept trying to pay me. I said no, and then he sent me his wife and then bought a package for his wife. So I ended up helping his wife with her back pain, and then he also went down. He has to do a lot more testing still, but he went down the route that he needed to because I was not the right solution for that patient.
And again, it's one of those things too, to your point on the business owner piece. It's like at the end of the day, if your goal is to just help people and lift everyone up, right? Rising tides raise all the ships in the water. I don't think you're ever going to have to worry about things from a business and financial standpoint, right? Like, I know you mentioned that you're cash based, where I am in Maryland. Currently, we're insurance based, which it's a battle sometimes, right? You face denials, you face low reimbursement rates, but again, it's like, how can I have a positive impact on others? And obviously, with needling, one of the things that comes up a lot is, hey, unfortunately, it's not covered by health insurances yet. So there's typically an additional cost to it. However, I do hope for a day where health insurance recognizes the power and effect that this can have, and if anything, actually help the system and save some money for people, right? If we can get them better and, 6 visits instead of 12, then hey, I'm willing to make that transaction every time. And yeah, it might cost a little bit more per session in the short term, but if it saves us in the long term, again, we have to be thinking bigger picture here instead of just what is going on and present in the moment. We talked about that in relation to the evaluation component. We talked about that with the application of the needles themselves, but even just as a whole and as a system, we always have to have that bigger picture mindset in addition to the in the moment mindset, I guess I'll say.
No, I agree with you. Like, yeah, it's not covered by insurance right now, but I do think it will be covered by insurance in the future because eventually they're going to realize that we're actually able to save a lot of money, a lot of healthcare dollars, get better outcomes for our patients. And I do think that it starts with us doing the right type of needling for our patients and getting those outcomes. So that way they can go back and tell their physicians that, like, look at the outcome that I got, and it was from this person doing this, and this, and needling me, or just educating these other providers that maybe don't believe in needling. Because if you go on social media long enough, you'll see that there's a lot of hate towards dry needling and spinal manipulation. But one reason for that is I truly don't think they know enough about it. I mean, there's a study that talked about dry needling for neck pain where they combined, there was one group that had traditional physical therapy and another group that had traditional physical therapy plus dry needling. Now, in the study, they say that their conclusion is that dry needling works well in the short term, up to 1 month, but has no long-term outcomes and it has no effect on disability and only helped in pain. But if you go back and read the methods of that study, they used 15 millimeter needles, which is not deep enough to get into the deep enough in the neck. They talk about getting into the cervical multifidi. 15 millimeters will not get you into the cervical multifidi. They also said they were looking for trigger points, which good luck palpating a trigger point in the cervical multifidi. They also did vertical pistoning, so they went back and forth. They used no electricity. They didn't wind the needle, and they didn't keep it in situ. And still, they had good short-term outcomes, even though they did all the wrong things. So people will look at a study like this, and I've seen this posted on social media where people will say, look, there's no effect on disability and there's no long-term improvements from needling. That doesn't tell me that there's no long-term improvements. That tells me that even if you suck at needling, you're probably still going to get an outcome. You could just have a better outcome. Comparatively, there's another study that was done really well in knee replacement patients where everybody was going to get a knee replacement and they were all knocked out on anesthesia and they needled half of them and they didn't needle the other half. And then the therapist did their follow-ups for their their PT sessions afterward. The surgeon didn't know who got needled, the patient didn't know who got needled. So it was a really well-blinded study. What they found from one needling session was that there was better pain up to 1 month later after the knee replacement, which is great because that means we can hopefully get more improvements in range of motion. Along with that, the 1 month improvement in the dry needling group was equal to the 6 month improvement in the non-dry needling group. So it just shows you a difference in as to how these studies are done and why some people may be confused by them. So I don't think that people that are posting on social media that are hating on needles just don't want people to get needled. I think they don't believe in them because they haven't gotten a proper education as to how dry needling works, what it can do. And for that reason, they start hating on it because they don't want patients to waste their money. But I would argue that if you are one, if you overdose a patient and they don't want it done again, or if somebody's hating on it on social media and a patient's following that therapist and they don't want to try it because someone else is hating on it, you may have done that patient a huge disservice because that could have been the thing that was going to get them out of pain. But I know that I have a lot of friends that are in healthcare, and some of my orthopedic surgeon friends didn't believe in it until I just had to like talk to them about it and let them know that there are studies that support this and it's more conservative than cutting somebody open and changing their knee. It is like we should be doing this way early on, and again it has to be done properly. You were talking about needling the calf earlier. I had a patient that I saw that was an NFL player that had an Achilles tendinopathy, and the team was only needling his calf. No one touched his Achilles. They also were not loading him appropriately and they had him stretching it. Bad ideas for an Achilles tendinopathy, but they were putting needles in his calf. He would get sore, and then his pain would eventually it went away to a point where he was able to play again, and then he got re-hurt pretty much his next game in like the next game in the season. When I saw him, they just put needles in the Achilles. You have to do it a little bit more conservatively when they like he was still in season when I saw him, so I couldn't really go aggressively on it. But if somebody has an Achilles tendon problem, sure, you can go into the calf. It's going to likely get you some benefit. They'll probably need it, but you should also be going into the tendon and you should know how to do that. Because if you go into a tendon and you're not properly training it, you could definitely cause more harm than good. But all that being said, when somebody's saying that dry needling doesn't work, I don't think they truly understand it. And or they've probably met people that have had bad outcomes because those that have needled them didn't really know how to utilize that tool. They used a hammer when they should have used whatever, a drill.
No, I think you said that really well, and you're absolutely right. It's one of those things that, again, the approach that one provider uses compared to the next can be drastically different, and as a result, the outcomes can be drastically different, right? You can have the same diagnosis, go to three different people, and get three different treatment plans. And, it's one of those things that I think the more we kind of standardize things with things like a common language, we talked about that earlier in relation to using the acupoint system instead of just sticking needles in everywhere. The more we can have this common language to discuss as providers, the better off we're all going to be, and the more kind of unified in the, quest of optimal outcomes for as many people as we can, we're going to be that way. And I realize we could talk about the physical therapy space and we can talk about dry needling in particular all day long because it's a topic where you are extremely knowledgeable and very passionate about that way. But I'm sure someone is going to have questions. They're going to want to reach out. They're going to want to talk more. Maybe they're even going to want to sign up for one of the many courses that you're teaching that way. Where can people find out more about you at online, Osama?
So if you were to look me up on Instagram, it's probably the easiest way. Well, I'm probably the only Osama Imam who is a physical therapist. So first name Osama, last name Imam. My Instagram handles at Dr. Crack and Needles.
I
So
love that, by the way.
DR period crack and needles. My website is dynamicdpt.com. The company that I work with where I teach dry needling is at spinalmanipulation.org. We offer a lot of different courses, not just dry needling, but also we are definitely the leaders in spinal manipulation. We have BFR courses, ultrasonography, pelvic floor dry needling, vestibular and concussion, instrument-assisted soft tissue mobilizations, diagnosis. So really robust program, offers a lot. I'd highly recommend you guys look into spinemanipulation.org. And then I also have an online group, which maybe you can post in the show notes. I'll also have it on my Instagram. That's called the Manual Method. It's just an online community. A lot of PTs, chiros, athletic trainers that are in there. Some like NPs, PAs, and we talk about patient cases. I show some different manual therapy techniques, so some different joint mobilizations, some soft tissue techniques. But also, I'm just one person, and I'm limited by my experience and my education. And there are a lot of people that have their own experiences and their own education that also can be a huge benefit. So the community really allows us to learn from each other and especially learn from other people's questions because sometimes people will ask a question where I maybe would have never thought of that. And it just kind of makes us all better because, like you said, Dan, a rising tide raises all ships. And I do think that this is the best way that we can help more and more people is instead of pinning all of the providers against each other, instead of pinning the PTs against the chiros, against the athletic trainers, against the osteopaths. I think that if we just were to work together, the only patient that's going to benefit is, or the only person that's going to benefit is the patient. And that is the ultimate goal, is getting the patient better. So that's why I have that online community.
That's awesome. Yeah, I love that. We'll link to all of that in the description below as well. That way, if you didn't quite catch it, you can just click there. And speaking from personal experience, you guys are the best when it comes to dry needling instruction. I took some courses that were not taught by you guys at AAMT, and I just feel like you guys did it the best that way. So highly recommend getting certifications there if you're looking for them that way. Osama, appreciate your time and everything you're doing, man. Thanks for everything.
Thank you for having me, Dan. I really appreciate it. This is a lot of fun.